Good evening, everyone, and welcome to our Progressive Chronic Kidney Disease webinar. My name is Helene. I'm the Workforce Development Coordinator at Westvic PHN, and I'll be your facilitator for this evening alongside Jade, who also works with me. I'd like to begin by acknowledging the traditional owners and custodians of our unceded lands and waterways. I'm dialing in from Wadawurrung country this evening. We recognise their diversity, resilience and the ongoing place that First People hold in our communities. We pay our respects to the elders, both past and present, and commit to working together in the spirit of mutual understanding, respect and reconciliation. We support self-determination for First Nations peoples and organisations. But just a little bit of housekeeping. You can view the majority of our webinar recordings freely on our YouTube channel, and the link to that is up there at the moment. And you can also see our upcoming events on the screen, and you can register for these via our website, and the link is also there for you. You may have seen that we have recently launched our new Learn and Network monthly newsletter. This is the best way to keep up to date with our latest education and events. So if you are yet to receive an edition, please subscribe via the link in the chat or scan the QR code now on the screen. Editions will be released on the first Tuesday of each month. Just a reminder about our Health Pathways, a free online resource with the localised clinical and referral information for health practitioners. Now, a certificate of attendance will be emailed to you all. So if you could take a moment just to check that your full name is displayed accurately on the screen. If not, or if you're unsure, just rename yourself or type your first and last name in the chat box. This will ensure that we can get your certificate to you. The event is being recorded, so if you could keep yourself on mute unless you would like to ask a question at the end of the session. We do encourage interactivity and discussion, so please feel free. You can type your questions in the chat box at any time, and I will answer those on your behalf at the end of the presentation, or of course you can take yourself off mute then. Your feedback is important, so if you could just take the time to complete the event survey after the webinar, and there'll also be a link in the chat, and I'll remind you again at the end. So I'd like to welcome this evening to our presenter, Dr. Karen Dwyer, nephrologist. I'll hand over to you, Karen. Thank you.
Great, thanks Helene, and welcome everyone. Thanks for taking some time out on your Wednesday evening. I am just going to share my screen, so just bear with me for a sec. All right, so my hope is that everyone can see the screen. I'd also just like to acknowledge the traditional owners of the lands that we're on. I'm actually dialing in from Wurundjeri country at the moment. I always like to start a CKD presentation with this imagery. So I was working at Kidney Health Australia a couple of years ago, and we put together, in conjunction with community consultation, the CARA guidelines for recommendations for culturally safe kidney care for First Nations Australians. And this was the accompanying artwork. And I think it just is a really nice description of the journey with kidney disease. So it's called Flow and Thrive, and it represents the many stages of living with a kidney condition. The turbulent waters on the top right symbolise the challenges that those on this journey face, while the mangroves to the left remind us of the resilience and strength needed to navigate these difficult times. The sunrise seen in the bottom right corner is a sign of hope for those on this journey, reminding them that they are never alone. The boats within the river represent the family, friends and support networks that provide comfort and encouragement, while the lines to the far left represent the medical practitioners and clinical personnel who offer guidance and care. Ultimately, this design stands as a reminder that those living with a kidney condition can weather the storms and find peace and growth in the journey ahead. So, thanks again to the Westvic PHN for inviting me to give this discussion. I am still on the PEAK committee at Kidney Health Australia, which really helps to formulate these primary care presentations. I'm sure everybody is aware of the CKD Management Handbook. This was one of the last things that I was involved with at Kidney Health Australia. So there's lots of blood, sweat and tears that have gone into putting this handbook together and making sure that, you know, it's up to date and everything was correct and accurate. So I hope it's a really useful resource. And then, of course, there is the CKD Go app. So hopefully you've seen that as well, which is just that portable version of the management handbook. So that's been updated as well. Of course, there's lots happening in renal disease at the moment. So, you know, I think we're going to have to do further iterations of the handbook, given the rapid changes in PBS criteria, for example. So tonight overall, we're looking to discuss the tools to drive early detection of chronic kidney disease in primary care, and then the optimal management. And with optimal management, this will be through following clinical action plans. We'll talk about when to refer to a nephrologist and briefly talk about treatment options when you do have someone with kidney failure, just so that you can, not that you're expected to oversee someone's treatment when they're on dialysis, for example, but clearly it's good to have an understanding of what they're going through. So we'll start just at the very start with what is CKD, which I'm sure you're all aware of. But CKD is defined as a estimated eGFR that's less than 60, that is there for at least 3 months, with or without evidence of kidney damage. And what does the kidney damage mean? That means either proteinuria or albuminuria, hematuria. There may be some structural abnormalities, or you may know that there's a congenital issue at play, or pathological abnormalities, and someone may well have had a renal biopsy. Of course, when we get somebody's eGFR, you know, a one-off measure, like with any condition, we like to repeat before we assign a label to that particular condition. And for chronic kidney disease, we do have this time frame of about 3 months where it's reduced. So we've got a few polls in the discussion tonight, so it'd be really helpful if you can talk these or fill them in at home. So according to the Reveal CKD study, what percentage of stage 3 CKD remains undiagnosed in Australian adults? Great, thanks for everyone. So we've got 10%, 30%, 60%, and no one's picked 90%. So hopefully our first learning point tonight, is that 90% of people remain undiagnosed with CKD. So most people are unaware that they have chronic kidney disease. The prevalence of kidney disease has increased. We used to quote a 1 in 10, and now we're quoting a 1 in 7. Australian adults have chronic kidney disease, and 90% are unaware. So there's a huge untapped pool there of people to diagnose and hopefully treat early enough to prevent progressive kidney disease. So it is overlooked. We've already talked about this, that it's very common. It's unrecognised, and it's unrecognised because it is silent. And I'm sure you've all heard this stat before, that 90% of kidney function can be lost before people experience symptoms. So it's something, it's like hypertension, I guess. The numbers can be changing, but the individual themselves is completely unaware. And that poses lots of challenges, doesn't it, in terms of diagnosing, but then also managing when someone feels well. And as a result, we have this concept of late referral, and it's relatively common. So nearly 20%. And what late referral means is the time between referral or being seen in a kidney service to needing to start dialysis, for example, is within 3 months. And we've got that 3-month mark because we need that sort of lead time to, for example, to get a fistula ready, to prepare someone for dialysis. So if we don't have that lead time, then we're really starting to need to use temporising measures such as vascular catheters and whatnot. So that that late referral number hasn't changed that much. It used to be perhaps low 20s, and we're slowly getting it below 20%, but still very significant that a lot of people are presenting very late. So today we're just going to go through, I think this is a really complicated case, and, we're going to travel back in time, and clearly so much has changed in the last few years that what we would have done back in time, it would be very different in today, in 2025. So perhaps we can talk about the differences. But we've got Max here, who's a 64-year-old male, lives with his wife, and he has a weight of 150 kilograms. At age 64, mobilising with a walking stick, I think, is pretty significant, but not needing any aids at home, is a non-smoker. And he's been referred to the ED with acute hypertension, and he's been transferred home with a request for follow-up and ongoing management. So his medical history's had hypertension for a number of years, diabetes for about the same, diverticulitis, cardiovascular disease, obstructive sleep apnea, obesity and metabolic syndrome, and he's had a gastric sleeve operation, and that was complicated by an AKI and UTI, which we'll go over a bit later. I guess I just would like to, pause and just really highlight that in those medical conditions, just the overlap of all of these conditions, the hypertension, the diabetes, the cardiovascular disease, OSA, obesity and metabolic syndrome, these things are all interconnected. And I'm sure you've heard of a syndrome called CKM. This is cardiac kidney metabolic syndrome. So that terminology was coined, I think, towards the end of 2023, and it really starts to bring these conditions together. It shows us that there's a unifying or overlapping pathophysiology, and if we move upstream, these things are all have the same driver. That's CKM. We can expand that even further, and there is another term called metabolic dysfunction associated kidney disease, and it's really the same thing. It's CKM, but it also recognises that OSA, a metabolic syndrome, gout, fatty liver, all these conditions are really driven by metabolic dysfunction, and so we have the same driver of all these conditions. And I guess this is really highlighted nicely with his medical history, because the years that he's had them they're all in the same ballpark. The obesity is the early driver with insulin resistance and metabolic syndrome. So that's sort of at 20 years. And then over time, we have the complications arising of diabetes and cardiovascular disease and kidney disease. The rest of his history, alcohol is occasional, and you can see the medications there. So an ACE inhibitor, a calcium channel blocker, ezetimibe, a statin, and a sulfonylurea, metformin, a gram BD. And, in 2025, we would probably have make some changes to those medications possibly, and we can talk about those as we go along. So this is a little bit of a timeline. As you can see, we're traveling back to 2012, and clearly we didn't have anywhere near the sort of the toolbox at our disposal as what we have now. But I guess back in 2020, there is lots that we could have done. Thinking back, we probably could have managed this this gentleman in a quite a different way, and hopefully prevented what happened sort of 13 years later. So 2012. With obesity, we've already got macroalbuminuria. So clearly we know that with obesity, it directly acts on the kidney itself. And so we get that leakage of proteinuria. Proteinuria is a really important marker. It's one of the take homes for tonight is to be measuring proteinuria through a urinary ACR. And that to me is a more sensitive marker of kidney damage than the eGFR, for example. So when I see proteinuria, I know that's I need to be quite aggressive. Whereas as you know, eGFR can fluctuate for multiple different reasons. And he already had very severe hypertension back in 2013 and 2015. and diabetes had emerged at that stage. As we move along, he's starting to get further complications, angina, heart failure, then a stroke and heart failure, before having the bariatric surgery, and only following that, possibly with probably some drug therapy, we've got control of hypertension and control of diabetes. And I guess this really shows us that tackling that root cause, which is really dysfunctional adiposity and insulin resistance, is really, really important. And it would have been great to have been doing this much earlier than in 2021. So over the 12 years, we've got lots of risk factors. You know, our classical risk factors of hypertension, heart disease, diabetes. But as I've just mentioned, you know, we do need to start thinking about these conditions as almost as one, that if someone has fatty liver, absolutely they're at risk for kidney disease. And for us to think that they're not is you know, I think we're missing an opportunity to really improve or prevent terrible end organ damage. So back to Max, and yep, there's multiple red flags in Max's history, and potentially could have been referred to a nephrologist, or there's lots that can be done in primary care, and we can explore those as we go along. So when do we check? When do we offer a kidney health check? And look, certainly if somebody has diabetes, we know that there's a high risk of renal involvement, but we also know that the complications from diabetes, it's a continuum. So with increasing hemoglobin A1C, there's increasing risk of complications. And that just doesn't start at 6.5%, which is when diabetes is formally diagnosed. That's happening even in the pre-diabetes range. So again, just brings us back upstream. The earlier we recognise the metabolic dysfunction, the earlier we can intervene. Hypertension, again, very tightly linked with metabolic dysfunction. If someone's been a smoker, current or former, and vaping is just an important thing to remember. That's central adiposity, so it's the key. The adiposity around the waist, that's the dysfunctional adiposity that creates the visceral adiposity with the chemokines, the adipokines that cause all the inflammation. If there's established cardiovascular disease, another reason why you would offer a kidney health check. Family history of kidney failure, so it's an important thing to ask for in your history taking. And if somebody has had kidney failure, it does increase the risk for the next subsequent generation, irrespective of what that individual, what the cause of the kidney failure was for the sentinel individual. If there's been a history of acute kidney injury, we know even with full biochemical recovery that there's an increased risk of cardiovascular, chronic kidney disease and kidney failure and even death. So it's really important to be aware of that. And in the absence of any of these other factors, we would offer a kidney health check to anyone that was First Nations Australian at age 18 or above, or non-Indigenous at 60 and above. And this is an important change that's come from the recommendations for culturally safe kidney care, is reducing the age to offer screening for someone that identifies as First Nations. And the reason being, we know that the burden of disease for First Nations Australians is excessive. The onset is at a much younger age. There is more rapid progression. We know that women are more affected than in non-Indigenous populations. So we need to be very vigilant and screen early. And so if we think about Max, he ticks a lot of these boxes and would benefit from a kidney health screen. And clearly had one back in 2012 because we know he had proteinuria. So how to detect CKD? It is easy. So there's three components. We need a blood pressure, we need a blood test, and we need a urine test. The urine test is for the urinary ACR and the blood test is for the EGFR. And we would offer this every 1 to 2 years. If somebody has diabetes or hypertension or is First Nations, we would offer that every year. Otherwise, we offer every 2 years. If someone's had acute kidney injury, we would offer it each year for the first 3 years. And if all's going well, then we would offer it less frequently. And once we've got the data, once we've got a blood test, an EGFR and a urinary ACR, it really helps us formulate the stage of kidney disease. But it's always important when you're thinking about the stage of kidney disease, trying to then think, well, what's the driver of it? And that allows us to really try and address the root cause of CKD, because it really is an end organ manifestation. What about the nephrology referral guidelines? And hopefully you're all aware of the guidelines. So if you're at all worried, so if somebody's got kidney function that's rapidly deteriorating, that's someone that you may need to refer to the emergency department, for example. So if they're rapidly deteriorating, if there's blood in their urine, if they're acutely hypertensive, if there's systemic symptoms to suggest some sort of vasculitic process going on, you absolutely would refer, and that's someone that might be treated empirically, might need a biopsy, those sorts of things. But assuming that there's not the very rapid change in EGFR, we have this EGFR guide, I guess, of around 30 mils per minute, at which point you might want to refer. And I think, guidelines are just that. They're just guidelines, and we always need to contextualize it to the person that you have in your consulting room. So if someone is quite young, for example, with an EGFR that might be 40 or even 50, you may refer them. So just say it's a 20-year-old, that's very abnormal for them to have an EGFR of, say, 40 or 50. Conversely, you might have someone that's 80 or 90 and their EGFR might be 29, and you may not refer in that situation. So it clearly does need to be contextualized, but at least the 30 gives you somewhat of a ballpark. If the EGFR is greater than 30, but there has been sort of this fairly steady reduction over a number of months, that may prompt a referral, even though you haven't reached that 30 mil per minute mark. If you have persistent proteinuria, that is a good reason to refer, and primarily because, as I mentioned before, it is such a sensitive marker of intrinsic renal damage, and really flags to me the people that are at risk of progressive kidney injury, but also those that are at risk of cardiovascular disease. And we'll talk about that when we get to the heat map a bit later. When you have kidney disease, and maybe without even kidney disease, sometimes blood pressure can be very difficult to control. So that refractory hypertension, absolutely, you might want to refer. And then there may be some other reasons that you would refer. We've talked about being, a youth, so a younger person. There might be a significant family history. And just also to flag that, like with screening at an earlier age, we also would suggest referring someone that identifies as First Nation a little bit earlier, once again, because we know that their disease can progress so quickly. So the reasons to refer, it can be helpful to refer, because we know that there are things that we can particularly support patients with. So, for example, some of the complications that arise with renal impairment, such as anemia, only we can prescribe the erythropoietin, for example. But we do know that it can also help with slowing progression to kidney failure and associated morbidity and hospitalizations. But really importantly, it does help us prepare for that next phase, and whether that be for dialysis or transplantation, which is kidney replacement therapies, Or maybe it's having the discussion around conservative kidney management and how we're going to coordinate that and share that with primary care. So it's a really important component, and that's where the late referral can become really problematic. In particular, if we've got someone that's got potential live donors, live for kidney transplantation, when we've got an early referral, that allows us to potentially transplant before needing dialysis, which is better for everybody. If you're interested on the Kidney Health Hub through Kidney Health Australia, there is a guide for how to refer, and that's easily downloadable. There's a number of other really useful things in the Health Professional Hub, such as sick day management plans and an actual referral template, which I think we'll show you a bit later on as well. And here it is. So here's the referral form. The really big one is the urinary ACR. This is a practice gap amongst many people, and as I said, I think this is probably it's more important than the eGFR in some respects. So the urinary ACR is really important. So let's go back to Max. And in 2012, with severe hypertension, so blood pressures of over 200, and nephrotic syndrome. Just to recap, nephrotic syndrome is, it's a significant amount of proteinuria, greater than 3 to 3.5 grams of protein in the urine per day, associated with peripheral edema and hypoalbuminemia. So that's that triad. Now, we can often have nephrotic range proteinuria, not necessarily with the hypoalbuminemia, and we see that a lot, say, with somebody that has diabetes, for example. So if it's truly nephrotic syndrome, it's likely that this man would have ended up with a biopsy. But if it's nephrotic range proteinuria associated with his diabetes, he may or may not have needed a biopsy. With just recapping his history of the obesity and the type 2 diabetes there. And so this back in 2012, perhaps this is some of the medications, perindopril of 10, so an ACE inhibitor with still, I think, first-line therapy. That's really important. We know it's got renoprotective, cardioprotective, cerebroprotective effects. Nifedipine as a calcium channel blocker is probably not one that I would use a lot these days, but certainly calcium channel blockers play a role. He has therapy for dyslipidemia, a sulfonylurea, which again in 2025 would be probably less likely to be prescribed. Metformin remains stable in the management of type 2 diabetes, and a DPP4 inhibitor with the gliptin also reasonable. But if we look at his test results, we know in 2012 there's many things in red here. Hey, I was going to say red flags, but they're all in red. So whilst he does have preserved eGFR, you can see he's got a urinary ACR now of 260 milligrams per millimole. So just to recap, normal for a man is less than 2.5. So, he's well above 2.5. Microalbuminuria would be 2.5 to 25. So you can see he's really moved into very overt proteinuria. If you want to know how much is that per day, a rough guide, just divide by 100. So it's somewhere around 2.6 grams per day. Now, I said before, nephrotic syndrome is 3.5 or 3 to 3.5 grams. So, it's in the ballpark. I suspect the degree of proteinuria is all related to diabetes, not truly nephrotic syndrome. But anyway, he's still got a lot of proteinuria there. His creatinine, his renal function is preserved with an eGFR of 90, but you can see he's got suboptimal diabetes control with a hemoglobin A1C of 11.4%, and a pattern of hypertriglyceridemia, which is the most striking thing there for me, with the low HDL. So this is all metabolic-driven disease, and clearly, if we could improve his glycemic control, we will improve his blood pressure, we will improve his dyslipidemia, we will improve his proteinuria. So I think, that would be an important area to target. So his EGFR is preserved, so it's greater than 90, but he has a urinary ACR, as I mentioned before, of 260 milligrams per millimole. Do you think he should be referred to a nephrologist? Oh, good. Everyone, yay. So that's good. So, yes, I think so. Like, because that's quite striking proteinuria. And back in 2012, in actual fact, there probably wasn't a lot we could offer specifically for the proteinuria. Clearly, it's the main driver is the diabetes and the hypertension, but nowadays there's actually even more. We've clearly still got to try and optimize the diabetes and the hypertension, but actually other agents that really directly reduce urinary ACR. So this is the heat map that I was talking about before, and hopefully everybody's seen this, and I think it can be really helpful, the visual. So EGFR is on the y-axis, and the albuminuria is across the x-axis. So if we go down the Y, his EGFR was preserved at greater than 90, but you can see that his his proteinuria falls into this red area, and the urinary ACR is greater than 30. So right at the border of yellow and red is 30. He was 260, so he's at the far end of the red box. So the more proteinuria, the greater the risk. So the risk doesn't just increase by 3, in 3 sections. It's a continuum as well. We know that if we can bring his proteinuria down, if we can go from 260 to 130, if we can halve it, that's going to reduce his risk for both cardiovascular disease and progressive kidney disease. It remains very high, but it's reduced. If we can move someone from a red to a yellow box, for example, then the risk certainly reduces. The color coding, I think, is helpful. So the yellow, the orange, the red, and the yellow, and that just reflects increasing risk of both progressive cardiovascular disease and progressive kidney disease. So red is the highest risk, orange, and then yellow. And of course, these then match match the color codes that are in the handbook or the CKD Go app and the action plans. Alrighty, so in 2016, we've still got uncontrolled hypertension, and some of the agents being used then is something like a atenolol. I have to say, I don't find atenolol to be that great from a blood pressure perspective, but clearly, this man is really challenging to manage. We're now using a valsartan, so an ARB with amlodipine. So we've still got that combination of RAS blockade with a CCB, but it's kind of nice to have a fixed dose combination. Moxonidine, hydralazine, probably not an agent I would use very often, and insulin's being introduced. And we can all understand why insulin's being introduced given the hemoglobin A1C, but as you all know, insulin really promotes weight gain, and so it becomes now a real vicious cycle, and hopefully we'll have time to talk about, what could have been done in 2012 to really address that diabetes. But let's have a look at his test results. So he's still got a preserved EGFR, which is great. Urinary ACR is much less. So it's 125. It was 260. So we've halved it. That's fantastic. Hemoglobin A1C is still 10.5%. And the dyslipidemia has improved. In particular, the triglycerides are reduced, which is good. 2017, we've now got cardiovascular complications, which is not great because he's a young bloke, really. So with the AF, brought in now a bixapan with a CHA2DS2-VASc score that would be at high risk. He's anticoagulated. Now we've got a PPI. We've got an antiplatelet agent. still got combined ezetimibe with a statin, but changed the statin exenatide. So now we're adding in a GLP-1. And of course, back in 2017, we'd probably be using something a bit different, but the GLP-1 has arrived, and they've just changed the antiplatelets. Again, looking at the test results, so preserved EGFR again, which is great. Urinary ACR is stable, but that diabetes marker is actually deteriorated 13.6%. The following year, now we've got congestive heart failure. So this is just the pattern, right? And we know that when you've got renal disease and proteinuria, your risk for heart disease, and in particular heart failure. And if we now think about 2025, we know these agents such as the SGLT2 inhibitors, yes, they do drop diabetes markers a little bit, or your sugar, but their main effects are through renal protection and cardiac protection. And it's because they drop the EGFR. And the cardiac protection is mostly through improving cardiac failure. So again, hopefully just highlighting how all these things are interconnected. And because he's got congestive heart failure, now we've got to bring in furosemide. So, there's just so many pills. We've really got polypharmacy happening now and Imdure. When we look at his test results, now we've got a creatinine that's 103 with an EGFR that's dropped at 69. Now, this may be because he was so congested, and the numbers look normal because he was so congested. And as you start to diurese, yes, the numbers may drop. But I always say people need to be able to breathe, so we've got to get the breathing right, and then we need to evaluate what's happening at the kidney level. Urinary ACR still in that macroalbuminuric range, but it hasn't worsened. But we're really struggling with diabetes control. So just that little bit on heart failure, really reiterating what I've just said. It's really, they commonly coexist, CKD and heart failure. And often it's HEF, so with preserved ejection fraction. Clearly some people will have HEF-REF, but if you've got someone that has, particularly if they've got obesity and diabetes and kidney disease, they absolutely will have an element of HEF. We've just got to look for it and you'll see it. So in 2021, Kidney Health Australia did publish an article called Make the Link, and it was essentially saying when you've got kidney disease and diabetes, think about the heart failure. And that's, again, what brings that CKM together. Cardiac, and it's primarily heart failure, kidney and metabolic disease. They all coexist. We used to often talk about it as cardiorenal, but I think the CKM is just a little bit more inclusive, so I tend to use that now. But it just shows that these, both heart and kidney, they really do talk to each other. So when the heart's not happy, the kidney's not happy, and vice versa. And so this can then become really complicated because unfortunately, despite the intersection of these two conditions, the guidelines, there's slight variation between the two. And I think that makes it incredibly challenging. And my hope is one day we can really harmonise those guidelines. It can be tricky to balance, improving outcomes and what's happening to their kidney function, and what about medications. It can be really challenging, and maybe we'll have time to talk about that later. Many of the agents that we use we do need to think about them in the sick day management, and there is a sick day action plan template that you can download from Kidney Health Australia. When someone's got heart failure, we think about the RAS blockade or you might use ARNIs and MRAs and SGLT2 inhibitors, and both of those go across both kidney disease and heart failure. So in 12 months, Max's EGFR has dropped by 21% to 69 mils per minute, and urinary ACR is 125. Are you going to, if you hadn't already referred, would you refer now? Or I think everyone did refer. So would we re-refer perhaps? Yep, great. So everybody wants to refer. Yep. And I think, this man's clearly at very, very high risk. So absolutely. 2019 now, he's had a stroke, more insulin. I can see why they're pushing more insulin, but we've got that vicious cycle with increasing weight. Urine renal function's pretty stable. Diabetes control 9.6%. We could get better. I think I've talked a lot about this already, the importance of albuminuria and EGFR in predicting kidney outcomes. And so on the left, we've got kidney failure, and on the right, progressive CKD. They're all on a continuum, so either or. But you can see that once your EGFR is below 60, it really does take off in terms of the risk. But I wanted to highlight on these graphs the different colours, so the blue, the green, and the red, and that reflects varying degrees of albuminuria. So blue is normal, green is micro, red is macro. And even with the same EGFR, you can see how that risk for progressive CKD just rises very rapidly as the degree of proteinuria increases. So let's have a look at end-stage kidney disease at EGFR of 60, and you can see with no proteinuria, the risk-adjusted hazard risk is at 4, but once you hit red, it's over 64, even though the EGFR is the same. So urinary ACR is critical. So back to Max, and it's 2020, it's COVID, it's terrible, and he's got angina and heart failure. And now we've got a lot of new things happening in the medication area. So the SGLT2 inhibitors have hit the market. So he's on empagliflozin, furosemide, and with the hydrochlorothiazide, so a tricky combination there, which we can talk about. Unfortunately, more insulin, but we're starting to win with his hemoglobin A1C, and we've got an ARB there. CCB is on hold. Metoprolol has been stopped, so this has been switched from the atenolol, and urinary ACR is pretty stable with that EGFR that's sitting at 60. This is very similar to the graph I've just shown before, but this is now looking at all-cause mortality and cardiovascular mortality, and it really just highlights the same curve. The numbers are slightly different, but the curve remains that once you hit below 60 and with increasing proteinuria, that risk for all-cause mortality really takes off, and most of that's from cardiovascular mortality. So we know the thing that people with kidney disease die of is premature cardiac death. So it is the most potent risk factor for cardiovascular disease, and in particular, it's the proteinuria. So in 2021, he has bariatric surgery and has that's complicated by an acute kidney injury, and later on, some more insults, and now has moved into stage 4. So kidney disease, so quite a rapid decline in EGFR, which may be all related to the acute injury. So from after 2021, after the bariatric surgery, hypertension, type 2 diabetes is better controlled, and you can see there's been some recovery of kidney function to CKD stage 3B. So this is the sick day action plan that I was talking about that you can download from Kidney Health Australia. It is really important to remember that there are certain medications that need to be stopped if somebody is unwell. And I tend to say, look, if you're unable to eat, you may as well stop it. So if you're unable to eat, you shouldn't take a sulfur because you might hypo. If you're not eating, your sugars aren't going to go high. So you can stop your metformin and stop your SGLT2 inhibitor just whilst you're not eating. If you're not eating for whatever reason, you're likely to drop your blood pressure. So you don't want to use your ACE inhibitor or your ARB if your blood pressure is a bit wobbly anyway. And if you're not eating, you may well be drinking, so you need to think about whether to withhold diuretics. But often if you're not eating, it's because you're unwell, and so you may want to just withhold the diuretics until you're back on track. So I think it's nice just to go through that, and it's good to be able to give somebody a piece of paper to take away with them as to what they need to do, because it is a little bit hard to remember. So back to Max, and he's got a lot of medications there. He's had that acute kidney injury. He's now got an EGFR of 40 with a urinary ACR of 49. So, you know, I actually think he's probably in a better spot now with an EGFR of 40 with a urinary ACR of only 49, as opposed to where he was with a EGFR of 90 and urinary ACR of 260. So you can see how EGFR alone doesn't give us the full story. Diabetes is much improved. And I think that's the power of that the bariatric surgery, and clearly if we could do something a lot earlier, and that's not suggesting surgery earlier, but a lifestyle intervention a lot earlier, we maybe we could have prevented a lot of years of poor health. And so in 2023, so we were 2021, his EGFR was 40, 2023 EGFR 42, so that's holding really nicely. And look at that ACR, we're now getting right down into the microalbuminuric range, so that's fantastic. Hemoglobin A1C a little bit worse at 7.3%. Quite a lot of medications there. And so where he's moved, so you can see we've moved from the top right, which was a red, but now we're into the orange, even though the EGFR is lower. So it's quite a nice case to really show that by really targeting urinary ACR, you can actually improve somebody's or reduce their risk for cardiovascular disease and progressive kidney disease. So the action plans, you've got the red action plan, you've got the orange action plan. So the red action plan should be followed when Max had macroalbuminuria, irrespective of EGFR. That's right. And we probably don't have that much time, so perhaps you can pop stuff in the chat, but I might just keep moving on just so that we've got time for questions. The color-coded action plans, whether you go through the handbook or the app, so they build on each other, so that you start at the yellow and then the orange and then the red, so it builds as you go, and hopefully that's fairly self-explanatory. Just kidney failure options, just to briefly go through that. When somebody's approaching kidney failure, it's really important to have the discussion about, what's important to that person, what are their values and their goals and their preferences, because dialysis is a really difficult treatment, and it's not something that it's not like writing a script for a pill. It's a really difficult treatment, and people on dialysis spend a lot of time in hospital, and the survival advantage of dialysis gets less and less as someone gets older and older, and particularly with comorbidities. So it needs that really careful discussion. Clearly, kidney transplantation, if somebody's well enough to be able to survive that operation and get through the first sort of 100 to 200 days, then kidney transplantation is a really great option. And then conservative kidney management, or comprehensive conservative care, is it's a really good approach in perhaps in someone that's older with comorbidities, and where we try to manage symptoms as best we can without dialysis. In terms of just a quick summary of these, so with dialysis, there's two options. It's peritoneal, so that's through when we put fluid into the tummy, and that's mostly done at home. We try to do the dialysis mostly at night so that people are relatively free during the day. And then hemodialysis can be done at home. The majority, though, have dialysis that's done at a hospital or a satellite centre of a hospital. Kidney transplantation, live donor transplant is the best option. So if there is someone in the family that can donate, or close friends, that's wonderful. But most people end up receiving a deceased donor transplant. To get one of those, you need to be on a transplant waiting list, and clearly we never know when a particular donor will be available. And then I've talked about conservative kidney management. I'm not going to dwell too long on this. Home versus in-centre dialysis. There's multiple reasons why someone might choose one or the other. Home dialysis does require a lot of training, but of course it creates a lot of flexibility, and we strongly encourage people to choose home if they can, but a lot of people can't. So a satellite or in-centre dialysis is the option. Advanced care planning is really critical for people with kidney disease. They do have a life-limiting illness, and it really does help us in that planning stage for kidney failure if we know what someone's values, goals, and preferences are. So we've talked about advanced care planning, and let's talk back to Max in 2024. You can see how his eGFR is now even improved to 52 mils per minute. So whilst I don't really like the term chronic kidney disease because it does suggest that things are chronic and progressive, but with really with early management in particular, but really addressing those metabolic factors, we can improve kidney function. We can improve the proteinuria, reduce the proteinuria, and you can see eGFR drop, but has improved. So the take-home messages: early detection is really important because we can treat. I'd love to have, and my other take-home messages here is that with early detection, it's urinary ACR, and the early treatment, the addressing those metabolic factors is so critical. It is the most important thing if we can identify those really early. So we really want to be very active in identifying people at risk of chronic kidney disease. And I'd really encourage you to think beyond diabetes and hypertension, cardiovascular disease. Of course, there's smoking, but that central adiposity, the presence of metabolic syndrome, fatty liver, pre-diabetes, these are the things that we can really make a difference with supported lifestyle intervention. The CKD Go app, using those action plans can be really, really helpful. And then, of course, trying to code that into your practice software. Kidney Health Australia have lots of really useful resources for patients, but also for practitioners, and the health professional hub is really great. This slide makes me laugh because Max has changed considerably from what he was in 2012. So go Max! I think we've done a good job. We've changed him biochemically and physically by the looks of that. And there's heaps of these health resources that are available to all to clinicians and to your patients. One thing that I'd just really like to flag: Kidney Health Australia has just launched an online program called Kidney Health for Life. And so anyone that in your practice that has chronic kidney disease, you can refer them to that program. You sign up online. It's a free program, and it takes people through a lot of education. There's some recipes. There's some advice on exercise and sleep, and it's quite a useful. This will be hopefully a really useful tool. And there, voila, there it is. So Kidney Health for Life is there. And this is your professional health hub, which is another hopeful useful resource. So there is a few minutes left. I'm sorry, I kind of rushed that last little bit because I thought it'd be good to stop for some questions. So I'll stop sharing and pop everyone back onto a full screen so I can see, and happy to take any questions if you have them.
I don't have any questions in the chat box yet. We still do have time. So if there's anyone out there wants to take themselves off mute or type a question in the chat box, please do so now.
I guess whilst we're waiting for any questions, I guess I'd just like to sort of think about or talk about that early intervention and what we can do in particular from a lifestyle perspective, because I feel that's the key. Particularly, now we've got all these agents. We've got the SGLT2 inhibitors. We've got the GLP-1 receptors, and they're really transformed how we think about managing these conditions. But we could actually be doing this a lot earlier through lifestyle. So those agents really, SGLT2 inhibitors, we know it blocks glucose reabsorption in the kidney. So you're weeing out sugar. You then subsequently drop your insulin levels. The GLP-1 receptors, they alter glucagon and delay gastric emptying, so you get less insulin. And to me, these are working because they're addressing that root cause. So early on, if we can be addressing that root cause, I think that's the key. How do we address the root cause? How do we reduce insulin resistance? So, we know exercise, in particular resistance exercise, improves insulin sensitivity, so it drops insulin resistance. We know good sleep reduces insulin resistance. But I think from a dietary perspective, we've got to be really cognizant that we're not further exacerbating insulin resistance. So it's addressing, sugar consumption, ultra processed foods, all these things that are really so pervasive. And our agents clearly don't work if we don't address those. And I think it's just so amazing. And we see it here with this gentleman, that he's had the bariatric surgery, which once again, it reduces the amount of food. So of course we're reducing that insulin surge. Then we start to get good diabetes control. Then we start to get good hypertension, blood pressure control. Then the proteinuria really reduced. So let's avoid the surgery by really addressing those dietary aspects, and then our agents are going to be so much more effective.
We do have a question. How
Yep.
strong is the evidence that NSAIDs are nephrotoxic? I'm thinking of people with OA. What about steroids?
Yep. So this is a really tricky area because, as you know, non-steroidals are really great analgesics. So there are two things with non-steroidal anti-inflammatory drugs. Yes, they are nephrotoxic. So long term, we know that they are nephrotoxic. They cause ischemia. So if you're on non-steroidals for a long, long time, absolutely, you might get ischemic damage to your kidney. There is also an idiosyncratic reaction to non-steroidal. So some people can develop a nephrotic type syndrome as a result of non-steroidals. So I always think it's good to use them in short bursts. If someone has chronic kidney disease, everything is a risk benefit, right? So when somebody's got chronic kidney disease, but they've got severe pain, a short course of non-steroidals is probably okay. And I use that. I even had one woman who had a kidney transplant and she had severe pain. The only thing that we could use was an anti-inflammatory. I tried everything else and she hallucinated and it was awful. And I was incredibly nervous because of giving her an anti-inflammatory, but she was fine. So I think it's okay for a short burst. But long-term consistent non-steroidals absolutely cause ischemia. But I think it's just balancing things. What else do I do? So I always have this discussion going, here's the risk. What else could we try? So for osteoarthritis, I often suggest glucosamine, and I'd say to people, some people get relief, but you need to give it a good go. You need to give it about 6 weeks. If you respond, fantastic. If you don't keep pursuing, because there are some people that respond, some people don't. But that's something that potentially is worthwhile. Steroids, there are so many complications with steroids. So I would definitely use a really short course of steroid for like gout. I think can be incredibly helpful. 1 or 2, maybe 3 doses of steroid for gout. But for osteoarthritis, where it's a long-term thing, once again, for osteoarthritis, insulin resistance is a driver. We know the real value of weight loss. We know the real value of resistance exercises. So I hope that's answered your question, Peter. I think there is a role for anti-inflammatories, but we've got to be really cautious.
what about finerenone?
Yeah, finerenone. So thanks, Deanna. So finerenone is a non-steroidal MRA. So this is now on the PBS for people with CKD and proteinuria in the setting of diabetes. So we now have what we are starting to call a pillar approach to the management of diabetes-associated chronic kidney disease. The first pillar is RAS blockade, whether it be an ACE or an ARB, but not both. Then an SGLT2 inhibitor. If someone still has proteinuria, then yes, add in finerenone. The main thing with finerenone to watch out for is hyperkalemia. So you just do need to keep a watch on that. But what we know is that bringing in a RAS blockade drops is renoprotective, antiproteinuric. It drops proteinuria a bit, but we have residual risk. We can add in an SGLT2 inhibitor. We drop that residual risk a bit further, but it's still there. Add finerenone, we drop it a little bit further. So these things are just those pillars that provide that more comprehensive renoprotection.
Thank you. I don't think we have any more questions. So I'm going to take this opportunity to remind you to fill out your evaluation. And thank you, Karen, once again. Fantastic presentation. Always enjoy it when you're here with us, and I'm sure we'll be back again in 2026. We do, at least 2 or 3 presentations from Kidney Health Australia in conjunction with them. So thank you very much for that valuable information, and thank you everyone for attending. It is being recorded, so if you've got any of your fellow workers that want to look at that, please give them that link. And so I will now end the webinar. Thanks, everyone.
Thanks, everyone. Bye.
Bye.